of the attack on MSF Hospital in Afghanistan, which led to the deaths of nurses and babies. Civilians and health workers should never be a target. And as my colleague and dear friend Mike Rand said last week, the weaponization of health is not helping anywhere. We need health and peace. We need peace for health and health for peace. And we need it now. In the time of a global pandemic, I urge all stakeholders to put aside politics and prioritize peace, a global ceasefire, and ending this pandemic together. Every day without a ceasefire, more people are dying unnecessarily. Out of solidarity and respect for those killed and injured, as well as all those nurses and health professionals working right now in some of the most difficult environments in the world, I would like to ask for a collective minute of silence to remember those that have been slain in their daily work to serve and save lives. Please join me. Thank you. Today, the 2020 World Health Statistics were published by WHO. There is good news that overall people around the world are living both longer and healthier lives. The biggest gains were reported in low-income countries, which saw life expectancy rise by more than a fifth since the turn of the millennium. Better maternal and child health care has led to halving of a child mortality since the year 2000, an achievement for the world. Furthermore, lower-income countries dramatically scaled up access to services to prevent and treat HIV, malaria, tuberculosis, as well as a number of neglected tropical diseases such as guinea worm. However, the report reflects that the rate of progress is too slow to meet the Sustainable Development Goals and will be further thrown off track by COVID-19. The new statistics shine a light on one of the key drivers of this pandemic, inequality. How is it that in 2020, approximately 1 billion people are spending at least 10% of their household budgets on health care? How is it that in 2020, over 55% of countries have fewer than 40 nursing and midwifery personnel per 10,000 people? How is it that in 2020, because of a failure to invest in preparedness, we now risk backsliding on child immunization, malaria, neglected tropical diseases, and HIV? The answer is that the world has not done enough to deliver on the promise of health for all. The COVID-19 pandemic is causing a significant loss of life, disrupting livelihoods, and threatening to undo much of the progress we have made. While the coronavirus is an unprecedented shock to the world, through national unity and global solidarity, we can save both lives and livelihoods and ensure that other health services for neglected diseases, child vaccination, HIV, TB, and malaria continue to both function and improve. During the World Health Assembly next week, we will discuss with health leaders from across the world not only how to defeat COVID-19, but also how we can build back stronger health systems everywhere. We have a once in a lifetime opportunity to prove that the world is more than just a collection of individual countries with colorful flags. We're one world that has more in common with each other than we would ever dare to believe. The pandemic has made it crystal clear that we're one world that has more in common with each other than we would ever dare to believe. The best defense against disease outbreaks and other health threats is preparedness, which includes investing in building strong health systems and primary health care. Health systems and health security are two sides of the same coin. If we don't invest in both, we will face not just health consequences, but the social, economic, and political fallout that we are already experiencing in this pandemic. Today, I joined leaders from the global health, human rights, and development institutions to draw the attention of political leaders to the heightened vulnerability of prisoners during the COVID-19 pandemic. Along with WHO's own guidance on prisons, I urge political leaders to enhance all prevention and control measures in respect to vulnerable populations in places of detention. Overcrowding in prisons undermines hygiene, health, safety, and human dignity. A health response to COVID-19 in closed settings alone is insufficient. We urge political leaders to ensure that COVID-19 preparedness and responses in closed settings are identified and implemented in line with fundamental human rights and are guided by WHO guidance and recommendations to protect human health. Furthermore, today the WHO announced the launch of the WHO Academy application designed to support health workers, and the WHO Info app designed to inform the general public during COVID-19. The apps are available in all UN languages: Arabic, Chinese, English, French, Spanish, and Russian. With these new mobile apps, the WHO is putting the power of learning and knowledge sharing directly into hands of health workers and people everywhere. The WHO Academy app provides health workers with mobile access to a wealth of COVID-19 resources developed by WHO that include up-to-the-minute guidance, tools, training, and virtual workshops that will help them care for COVID-19 patients and protect themselves. Furthermore, in response to COVID-19, WHO has utilized our Open WHO platform and translated guidance into training, including 68 online courses to improve the response to health emergencies. It now has more than 2.5 million enrollments and hosts free trainings on 10 different topics across 22 languages to support the coronavirus response, including our first course in Swahili this week. Every day, we learn more and more about COVID-19, and new apps and courses for health workers and the general public allow us to disseminate information quickly and effectively. Sharing experience and best practices is critical for strengthening our response to the pandemic. Learning together is key to building national unity and global solidarity, so that together we accelerate progress faster and build a better world for us all to live in. I thank you.
Thank you very much, Dr. Tedros. We have shared with journalists several press releases on topics that have just been mentioned now. We will start with question As we had in the previous weeks, you can ask question and listen to this press conference in 6 UN languages, plus Portuguese, plus Hindi. Our interpreters that we would like to thank are here to help with that. If we are okay, we will start with Jennifer Rigby from Telegraph. Jennifer?
Hello, hi. Yeah, Jen here from the Telegraph. I wanted to ask, please, have you been tracking attacks on healthcare workers that are linked to the pandemic, and how concerned are you about those attacks?
Thanks for the question. We have a system for tracking attacks on healthcare which we've operated since 2017. As you can imagine, that system is very much focused in zones and countries of conflict around the world, and it has heavily focused in those countries where we've seen horrific attacks on healthcare, like the most recent one in Afghanistan. And again, my personal condolences to the people affected and to our great colleagues in MSF. They've always been brave, courageous, and in the front line. We are increasingly concerned about a whole range of attacks, not necessarily on healthcare facilities related to COVID, although there have been situations where isolation facilities have been, in a sense, not attacked in the military sense of the word, but where there have been public unrest around those facilities. And again, we would like to separate here in our minds what are the direct targeting of healthcare facilities and the healthcare workers for the prosecution of war or conflict, which is the most abhorrent weaponization of health that you can possibly imagine. We need to separate that from what is, in this case, in COVID-19, very often uninformed, very often overreactions from individuals or communities who don't fully understand. They themselves are sometimes scared, and in that sense I don't equate these two things together. It's very important. These aren't targeted, perpetrated, organised problems, but it does nonetheless have a huge impact on individual health workers, particularly when we've seen assaults on health workers themselves, because they are health workers dealing with COVID and are perceived to be bringing a risk back to their community. We've seen some assaults on COVID patients themselves, equally seen as a potential risk in communities. And just in April alone, we've noted more than 35 incidents in over 11 countries that were, more than there were quite serious sort of events involving attacks on individuals or groups. So, and some of this again we have to look at in terms of the way that COVID-19, in a sense too, has a lot of other issues have arisen around human rights and on the profiling and targeting of ethnic groups or ethnic minorities. We've seen similar issues arise around blame from settled communities versus communities that might be migratory. So I think, in a sense, COVID-19 is bringing out the best in us, but it's also bringing out some of the worst. It's bringing out reactionary groups. It's bringing out enhancing discrimination, and it's in some way we're seeing the facilitation of extreme responses in which people feel empowered to take out their frustrations on individuals who are purely trying to help and help communities. So I think we have to be sensitive to the fact that sometimes this happens because of misunderstanding and lack of information and education, and in other times this is senseless acts of violence and discrimination that must be resisted, and we also need to be sure that our words as leaders are condemning and not facilitating and enabling such behaviours. Thank you.
Thank you very much, Dr. Ryan. Next question is from Andrew Calbert from CBC News in Canada. Andrew? Andrew, do we have you? You need to unmute. Yes, please go ahead.
Thank you. On March 11th, you rung the international bell that we had a pandemic. So I'm curious what conditions need to be in place for you to unring the bell, let's say, for there no longer to be a pandemic. Is that to do with the finding of an immunization, or if you could just sort of expand on what conditions and be specific? Thank you.
I can begin. I don't know if you were using the alarm bell analogy or the boxing analogy, but there's a long way to go before there's going to be any bells unrung in this response. So I think we need to be clear about that. Countries, as you've seen, are trying to find a path out and a path towards a new normal, as many people have put it, and we're going to be on that pathway for a long time. And as we've seen in some countries, even a small recurrence of disease can cause and the need for a serious response in terms of the public health response. So I think we're going to have to remain on alert, stay the course, and ensure that we're ready to respond. In terms of reducing the alert, I think one of the issues arises. The WHO has been given a binary system by our member states. It's not the choice of the Secretariat. So member states decided we either have a global public health emergency or we do not. And in that sense, from an official perspective, that is, they're the choices we have. We can obviously, as time moves on in our risk assessment, reduce the level of alert at national, regional and global level through our systematic risk assessment process. At the moment, we obviously consider the risks to still be high at all national, all regional and at global level. But as time goes by, we will seek to adjust those risk assessments and move them down. But that is going to require us reaching a point of very significant control over the virus, very strong public health surveillance, and stronger health systems in place to cope with any recurrent cases. But there is no formal system of de-escalating this other than for WHO to change its national, global and regional risk assessments. And obviously, as I said, the IHR only allows WHO two choices. There is either a global health, public health emergency, or there is not.
Thank you very much. Next question comes from Georgia. Konstantin.
To what Mike said, with regard to the alarm, the highest level of alarm for WHO was actually raised on January 30th. And this is when in the rest of the world we had only 82 cases of COVID and 0 deaths. So raising the alarm should be associated actually in the highest level based on the IHR. Of course, many countries would like to get out of the the different measures that are being taken by the country, by many countries, and that is rightly so. But our recommendation is still the alert at any country should be at, and whatever measures we take should be a very phased one that reflects the country's situation while investing in the comprehensive package that we have been advocating for. So while opening a country, still the alarm in each country can stay as high as possible, and we can do everything.
Not only by tradition, but also by economic necessity, to live in extended families without possibilities to distance or isolate. Our social behavior and welfare situation are very different, to those of Sweden or Baltic countries. My question is, in the future, will you issue country-specific guidelines accommodating specific social and welfare context? How in this situation, where distancing is not an easy option, we can protect the most vulnerable groups? Thank you very much.
I can begin on Georgia. I think Maria will come in, and I think you make a very, very good point in the second part of your question around how can we ensure that the local context, and it is important that they are. We have seen the impacts of lockdown measures in lower income settings, which are having a deep impact on people's lives. So we have to be very, very careful that we offer advice that can be adapted at national level, and we have issued subsequent advice for adapting our global guidance to refugee camps, to low income settings, to various other settings, and Maria can speak to that guidance. With specific respect to Georgia, I think Georgia's been in a very flat growth curve over the last couple of weeks, and has obviously kept cases down to under 650, and doubling time of cases of weeks now. So I think there's only been a 6%